Thanks everybody for coming. I would like to introduce our two presenters today. Our first presenter is Dr. Alexandra Filippakis. She is a board certified neurologist and multiple sclerosis specialist. She completed her neurology residency at Tufts Medical Center in Boston and her multiple sclerosis fellowship at Brigham and Women's Hospital and Mass Gen Hospital in Boston. She's the medical director of the Wentworth-Douglass Hospital MS Center. She serves on multiple committees in the New England chapter of the National MS Society, where she has also been named partner in MS Care. Her goal is to provide comprehensive and compassionate care to her patients. And our second presenter tonight is Karissa Mondoux. Karissa is a physical therapist with her Doctor of Physical Therapy degree and MBA in Healthcare Administration. She has been at Wentworth-Douglass Hospital for the past 5 years. Karissa is a department team lead and is part of the Wentworth-Douglass Neurological Rehabilitation Team. Her practice is focused on evidence-based neurological and geriatric rehabilitation. Her professional goal is to help her clients achieve independence in their lives and return to the activities they enjoy. And as Linda just said earlier, don't forget to use that question and answer button if any questions pop up during the presentation. And I will leave you with Dr. Filippakis.
Thank you very much, Bree, for that kind introduction. I'm going to share my screen here. All right. So thank you everybody for joining us. As some of you may know, March is Multiple Sclerosis Awareness Month. So I just wanted to talk to you all about MS, some basic information about what MS is, how we treat it, and some updates regarding multiple sclerosis and the COVID-19 pandemic. I have no financial disclosures to report, and all images from this presentation were taken from Google. Okay, so what is MS? Multiple sclerosis is an autoimmune, demyelinating, inflammatory disease of the central nervous system. So that there's a lot to unpack there. So simply put, MS is an autoimmune disease in which the body's own immune system attacks and causes inflammation in cells in the brain and the spinal cord, leading to a variety of symptoms depending on where that inflammation occurs. And as you can see here, there's quite a variety of different symptoms that can be caused by multiple sclerosis, ranging from motor symptoms to sensory symptoms, bowel and bladder symptoms, fatigue, cognitive dysfunction, pain, dizziness, mood disorders. And a little bit about the background on the disease itself. It is a disease that is more prevalent in women than in men. There's about a 3-to-1 ratio. It is more common in the Caucasian population and people of Northern European ancestry, especially in the Scandinavian countries like Sweden. There is a higher risk with coexistence of other autoimmune diseases like lupus, rheumatoid arthritis, type 1 diabetes. The typical onset is between age 20 and 50, but there are outliers on either side of that curve. And where we are in New England, the incidence of MS is about 1 in 1,000, which is not terribly uncommon. So what causes MS? MS is actually a multifactorial disease. There is not one single thing that causes somebody to develop multiple sclerosis. Different factors that have been identified in the development of MS include things like vitamin D deficiency, and even where somebody lives. We know that people who live further away from the equator and who get less sunlight and thus less vitamin D are more at risk. You may have seen in the news recently another factor that is definitely involved in the development of MS is infection with a virus called Epstein-Barr virus that causes mononucleosis. Family history and genetic factors play a role. Autoimmunity. So as I said, patients who have other autoimmune diseases, and some people have a predisposition to these sorts of disorders. Smoking certainly plays a role as it is pro-inflammatory, and obesity, especially childhood obesity, seems to contribute to the development of MS even after childhood. There are different types of MS, and I'm going to talk about relapsing MS and progressive MS. There are that can be sort of subdivided, further than that. But basically, I think what's important to keep in mind is that relapsing MS is the more common form of MS, and it is it is the kind of MS where people develop certain symptoms and then they get better. And then they have another, what we call attack or relapse or exacerbation. A lot of these terms are interchangeable, and then they get better. In progressive disease, there's more of a gradual disability over time. Year after year, somebody's walking might become worse and worse, their balance. So different, these subtypes of MS look a little bit different. There is, of course, some overlap, and some patients with relapsing disease, sometimes later in the course of their disease, may develop a progressive type of MS. How is MS diagnosed? Well, first of all, of course, in the clinic, we take a detailed history. We do a comprehensive examination. And MRI remains a very important part of diagnosing MS. In the picture you see here, we're looking at an MRI of the brain, and you see these sort of fluffy white spots against a darker gray background. These white spots should not be there. These are the MS lesions or the MS plaques, little areas of inflammation that have damaged the brain tissue. We also do blood work, and that blood work is mostly to rule out other disorders that may mimic multiple sclerosis. And at the end, if there's still some uncertainty as to whether or not someone has multiple sclerosis or not, doing a spinal tap searching for certain proteins, immunoglobulins in the spinal fluid, can help us to definitively make the diagnosis. So in terms of management, we think about it in two categories. How do we treat a relapse or an attack when it occurs in patients with relapsing MS? So I'll talk about that first. It is definitely more of a simple topic. The first thing I would say is that when somebody has new symptoms that they're reporting, we want to make sure that those symptoms are in fact due to MS, that they're due to a new lesion that is actively inflamed. And that's based on, again, history, exam, and MRI. And if we decide that that's the case, what we typically treat patients with are steroids. The most common route of administration is intravenous. We do IV methylprednisolone, usually for 3 days, sometimes 5 days in a row. More recently, there's been actually some data that oral steroids may be just as good in some cases. So if people have some difficulty getting to the infusion center, sometimes we might opt for that. And very rarely, in some patients who cannot tolerate steroids or have an allergy or have had an adverse reaction in the past, an ACTH, which is a hormone that comes in a gel formulation, can be used instead of steroids. One point that I'd like to make is that every relapse is different, of course, with MS, because it really depends on where that lesion is occurring, where that inflammation is occurring. Some relapses may be mild, maybe causing just some numbness and tingling in an arm or in a hand. And some, unfortunately, can be very debilitating, affecting somebody's motor functioning, their walking, their vision. And really, depending on the severity and the how much it is impairing somebody's life, that's how we decide whether we treat the relapse or not. So if somebody's having a mild relapse, we may opt not to use steroids, because using steroids during a relapse doesn't actually change the overall course of somebody's disease. So how do we change the overall course of somebody's disease? How do we try to slow down the progression of this disease? How do we try to reduce the number of relapses that somebody has, the number of new lesions that they develop over time in their brain and spinal cord? We use medications called DMTs, or disease modifying therapies. And there are over 20, believe it or not, disease modifying therapies that are currently FDA approved. The first one, the beta seron, was approved in 1993. So before 1993, there was essentially nothing to treat multiple sclerosis aside from using steroids for relapses. And now in 2022, and in more recent years, actually, we've had at least one new medication approval per year. So at this, and the landscape of MS therapies is now, the question isn't, that we have limited options. It's that we almost have too many options, and it's overwhelming sometimes for patients. How do we choose them? And that's where we come in as the MS team, and try to figure out, based on somebody's disease severity, somebody's other conditions, other medications that they're on, which disease modifying therapies would be appropriate for them. And often there's more than one right answer. This is a very busy slide, so I'm not going to read off all these medications for you, but I think a nice way to think about these DMTs is to categorize them as, actually there's more than one way. One way is to think about them as injectable medications. So these are self-injections at home, like an EpiPen, or like an insulin injection. And then there's oral medications that are pills, and then infusions that are done at the infusion center, where an IV is placed and a medication slowly drips into the vein. A few years ago, we used to say the injectables are the least effective or potent. The oral medications are somewhere in the middle, and the infusions are the strongest MS medications. But there are, with some of the newer medicines that have been approved in the past couple of years, there are some exceptions, and those are the ones that I have italicized and asterisked, because Kesimpta, for example, is an injectable medication, but it is actually a high efficacy therapy. And likewise, in the oral medication category, the last one, Mavenclad, is also a high efficacy therapy, but it is a pill. So as not to confuse you, but I just wanted to express that there are a multitude of different options, and which is great, because it's often not difficult to find something that fits for a particular patient. Another question that we get a lot is about stem cell therapy for multiple sclerosis. Some of this is in the news frequently, talking about clinical trials, and then also, unfortunately, there's a lot of sort of non-authorized, cash only, foreign-based places that offer very questionable stem cell therapy that can be quite dangerous for patients. In the United States, what's been studied and approved is stem cell therapy for very select patients. These tend to be young patients with very, very active disease that we cannot get under control with the multitude of medications that we saw in the last slide. And I used to say that stem cell therapy is definitely not effective in progressive MS, but I did italicize and asterisk that last night as I was reviewing my slides, because over the past 6 months or so, there have been some small clinical trials looking at stem cell therapy in the progressive population. And there is actually some positive data, but these trials have been very small, so we are awaiting larger trials. And I guess the other important point I'd like to make to you is that if you want more information about these therapies or are considering them, I would urge you to speak to your neurologist and to ensure that what you are seeking is something that is safe and appropriate for you. So what are the treatment options for progressive MS? So the past couple of slides were especially that slide where I showed you the over 20 multiple sclerosis DMTs. These medications are by and large approved for what are called relapsing forms of multiple sclerosis. There is one FDA approved medication that is approved for primary progressive multiple sclerosis, and that is the infusion Ocrevus or ocrelizumab. And there are actually two of the medications that are approved for something that we call active secondary progressive disease. And these are patients that are just transitioning from progressive disease into, transitioning from a relapsing form of MS towards the more of a progressive form where they've had some recent disease activity in terms of brain lesions and clinical attacks, but they are really starting to become more progressive in terms of accruing their disability. So currently, we have no medications or therapeutics for what we call inactive secondary progressive. So for patients who have been in that progressive, have crossed over from relapsing to progressive MS for many years, have not had any new lesions, any new disease activity, any new relapses for over 2 years, this is a big treatment gap currently in the MS world. Thankfully, clinical trials are underway to address this treatment gap. I was actually attending a small conference this morning from the Brigham where I was doing my training, and they are actually have started a very, very small trial about a nasal spray monoclonal antibody that may be effective in this population. So there's certainly more to come, and there's definitely reasons to be hopeful about this. So aside from, of course, treating the disease itself with these medications that slow down the progression of the disease, we can also, of course, treat somebody's symptoms. As you might remember from that first slide, where there was a laundry list of symptoms that may occur in multiple sclerosis, there are just as many treatments for these symptoms. We can treat somebody's overactive bladder symptoms. We can treat somebody's depression. We can treat somebody's fatigue, somebody's nerve pain and muscle tightness and spasticity. So even in patients who are not on disease-modifying therapies for whatever reason, there is still treatment for these patients in terms of addressing daily symptoms, quality of life, and daily functioning. And some sort of non-pharmacological treatments I'd like to bring up that certainly help in symptom management and even overall disease outcome would be smoking cessation. We do know that people who smoke that have MS don't do as well in the long term. They tend to have more relapses and more disability progression. That's not so much of a surprise because we know that smoking induces more inflammation in the body. Another useful tool in treating and managing MS is eating a healthful diet. And there's been a lot of studies on very different dietary strategies, ranging from extreme to sort of, what may be called anti-inflammatory diet, or even really sort of a Mediterranean diet. Sometimes, we tell people, sort of a heart healthy diet is the way to go because patients with MS are likely to die from the same things that everybody else is in this country. It's heart disease. I would say recently there's, I would say, increasing evidence that eating a whole food, meaning, no processed foods, takeout and fried foods, low sugar, and mostly plant-based diet, or at least trying to reduce animal products, has been shown to have, some anti-inflammatory effect. So that is something that people are able to do in varying degrees. So it's something that certainly is encouraged. Exercise, however somebody can, and really every level of disability and every phase of the disease, an exercise program can be recommended and modified for our patients. And exercise is certainly very important. And the rehab piece and assistive devices, I will not talk about because Karissa will talk about. And lastly, I just wanted to touch on, what has changed about treating and managing MS during the pandemic, and I would have to say quite a lot. Where the discussion around choosing an appropriate medication for somebody, how immunosuppressive that medication may be, how at risk someone might be of developing COVID or a more severe course of COVID, definitely goes into our decision making. And in fact, some of the medications that we use or have used on sort of standardized dosing intervals, we've actually sort of customized or personalized the dosing intervals of some of these medications in order to make that balance of suppressing somebody's immune system enough that we are controlling their MS, but not too much that we are making them dangerously susceptible to COVID and other infections. I would also say that during the pandemic, we would have thought more about how frequently to use steroids to treat somebody's relapse. Of course, if these relapses are mild, because of course steroids, along with these disease-modifying therapies, are immunosuppressive and can put patients at risk for developing not just COVID but other infections as well. Another thing I would say has changed in daily practice for MS doctors is thinking about even stricter safety monitoring for certain medications. I would say we've always had, of course, safe, and maybe strict isn't in the right word, but of course we monitor patients in appropriate ways with lab work, with MRIs who are on certain medications. But I'll give you an example. Some medications that work by lowering the white blood cell count, that lymphocyte count, before COVID, we would be comfortable letting that count ride down a little bit lower than we do now. So we might try to adjust things to make sure that the somebody's white blood cell count and thus infection risk isn't quite as much as it was pre-COVID. Another big topic that we talk about probably every day with our patients is the importance of vaccination, certainly COVID vaccination, but also flu vaccine and pneumonia vaccines, shingles vaccines. But I'll speak specifically about the COVID vaccine because I do frequently get a lot of questions about this. And I will say, and this is not just coming from me, but coming from the MS Society as a whole, that and this information has been gleaned from clinical trials and over 2 years now of safety and data monitoring, is that the COVID-19 vaccines are safe and absolutely recommended in all our patients with MS, regardless of if they are on a medication and regardless of which medication they are on. The only caveat I will add is that there are certain medications where timing may be a consideration in terms of when the best time to get a vaccine so that it can be the most effective during somebody's treatment cycle. For example, if they're receiving an infusion every 6 months, sometimes we need to wait a little bit until somebody's had their infusion so that their body can mount the most robust immune response possible. The other thing I will say is that although, of course, things have gotten better overall since the beginning of the pandemic, it is not over. We're still living in this pandemic, and I would say especially patients with multiple sclerosis and their loved ones absolutely still need to be vigilant with hand hygiene and masking. So in summary, I just wanted to relay that MS is not curable yet. We of course are working on curing and eliminating MS, but many treatments are available, and those are both disease modifying treatments as well as symptomatic treatments. And I would say the prognosis for a multiple sclerosis in most patients in this day and age, where we're able to diagnose somebody early, get them on treatment right away, and get them on good treatment right away, people do much better. Of course, pre 1993, when there were no disease modifying therapies, and the disease would run its course, it wouldn't be uncommon for somebody 15-20 years into the disease to become disabled, perhaps wheelchair bound. But this is happening at much lower rates because of these medications and interventions that we have available to us. The disease still remains, of course, an unpredictable one, but like I said, patients that receive early diagnosis and treatment, I would say, tend to do well. The presentations of MS, initial symptoms and attacks, are variable because the development of lesions in different parts of the brain and spinal cord do occur in different locations and cause different symptoms. So everybody's MS is not the same, and we really need to personalize treatment, and we're lucky to be living in an era now where we're able to do this. We're able to personalize somebody's treatment, and and especially during the pandemic, this has really has been an area that has been in the forefront of MS management and research. And how do we best personalize a safe and effective treatment for our patients? There's as you may have realized, I have talked about research, and there is a lot of research going on, not just at Mass General, Brigham and Women's, but all over the world. And another another interesting topic that I hope in the next few years we'll be hearing more about is development of remyelinating therapies, and these therapies would be to repair the existing damage, to repair the insulation around the nerves that has been damaged by the inflammation. And this could reverse existing symptoms and lead to a cure. So I think there are a lot of things that we can be optimistic about in the next 5 to 10 years down the road. But even so, today we do have wonderful treatments, and we are really able to, in most cases, control somebody's disease and really positively affect their quality of life. Thank you very much. And as Bree said, we are here to help, and we are happy to see you anytime and to be of service to you. I'm going to stop sharing my screen, and I will hand it over to Karissa.
Thank you, Dr. Filippakis. I'm going to share my screen. All right, so I'm Karissa Mondoux. I'm a physical therapist at Wentworth-Douglass Hospital. And even though I'm a physical therapist, I'm going to talk about rehab services in general for the treatment of multiple sclerosis. I also have no relevant financial relationships to discuss for this presentation. So as Dr. Filippakis mentioned, there are a wide array of symptoms for multiple sclerosis, and not everyone has all of them, but they can range quite a bit. Some of these symptoms can include fatigue, cognitive impairment, depression, unstable mood, nystagmus, which is an involuntary rapid movement of the eyes, optic neuritis, which is inflammation of the optic nerve itself, diplopia, which is double vision, dysarthria, which is difficult or unclear speech, dysphagia, which is difficulty with swallowing. There can be weakness, there can be spasms, there can be ataxia, which is a lack of muscle control and coordination, There can be overall pain. There can be hypoesthesias, which is reduced sense of touch. There can be paresthesias, which is an abnormal sensation. There can also be incontinence of bowel and bladder, diarrhea, constipation, and frequency or retention of urine. So obviously rehab can't necessarily help with all of those symptoms, but in addition to seeing your neurologist, rehab can benefit in a lot of those areas. The biggest one is mobility. So obviously we want to keep you as independent as possible and able to participate in your life as safely as you can. With that comes strength training. There's also tone management. So we naturally have tone in all of our muscles. That's how we hold ourselves up. And with multiple sclerosis, you can either have an increase or a decrease in tone. If you have an increase in tone, that's what we call spasticity. And if there's a decrease in tone, then we call that being flaccid. So most common one people might be aware of is like a foot drop. Fatigue, aerobic endurance and capacity. So there's an overall activity tolerance and really just your quality of life. So we know, as Dr. Filippakis said, that this is something that goes on for the remainder of your life at this point. So we want to keep you as active and as participatory in your life and as happy as we can. So what rehab services are available? So at Wentworth-Douglass, we have physical therapy, we have occupational therapy, and we have speech therapy. Wentworth-Douglass also has a comprehensive multidisciplinary multiple sclerosis program that Dr. Filippakis was part of developing. And with that, we round on patients that are seeing multiple services and just really helps with that comprehensive look at the patient. So physical therapy as a whole. So we will assess and treat for any mobility, strength, flexibility, balance, coordination, tone, and safety needs. We can also work on energy conservation and compensation techniques due to dizziness, any balance impairments, impaired sensation, fatigue, and vision impairments. And more specifically, we include aquatic therapy. We have pelvic floor therapy if you're appropriate. We can do home safety evaluations, wheelchair evaluations, and we can make recommendations for assistive devices. So that could be a walker, a cane, kind of those steps that we get to before needing a wheelchair. Biggest thing for physical therapy is even if it's not something that we can necessarily change. So obviously we can help with strength and we can help with balance and overall mobility. Biggest thing, like I already mentioned, is just making sure that you're safe. So sometimes we do need to take into account compensation techniques instead of kind of rehab techniques. So something like if you get dizzy in the morning due to where the lesions are, giving you strategies to make sure that you're the safest at that point in time. Or if your vision is impaired, making sure that you have your home set up appropriately so that it's safe for you, so you're not tripping over rugs or having difficulty getting to the areas of your home that you need to. Occupational therapy. So biggest things that occupational therapy work on are activities of daily living, which can include dressing, cleaning, cooking, taking care of children if you have that you have at home. They can also work on home and work environment accessibility. So same kind of thing as what physical therapy can work on too, but they can give you recommendations for the appropriate setup at your desk if you have a desk job, or where to place things in your kitchen so that they're most accessible to you. They can work on gross and fine motor skills. So that can be things such as buttoning your shirt, tying your shoes, if that's something that's difficult for you, or it can be gross motor, which is bigger movements such as pulling a shirt over your head, working on transfers. They can also work on tone. They usually take kind of the arms and the upper body, and physical therapy will work on the lower body. They do a lot with sensation, so they can help with some of those paresthesias that you're having or the abnormal sensations. They can work on the strength and the coordination of your arms. They can help with vision therapy, especially if it is something like double vision. They have tools that they can work on with you, such as they have goggles that they can use. They have a TV screen that moves in all kinds of crazy ways and you have to keep up with it. But they can also just make charts for you that you have to work on scanning, or you have to work on focusing with the eyes a little bit more. And then they can also work on energy conservation. They can recommend and provide you with assistive devices and visual aids. So typically they will work on more giving you like reachers and grabbers. They can work on long-handled equipment with you. They can work on built-up utensils or weighted utensils, or built-up writing devices, so that if you have a difficult time with writing or feeding, then you can be able to do that independently. They can do driving assessments, kind of what your reaction time is and your motor planning. They can also do home safety evaluations, and they can do functional capacity exams, which are a longer exam, but just to see how fit for work you are, pretty much. Speech therapy. So speech therapy doesn't just work on talking. They work on assessing and treating for swallowing difficulty also. They can work on slurred speech. They can work on unclear articulation of words. Dysarthria, which is the difficulty with words due to some like tongue and mouth weakness. They can work on dysphonia, which is kind of the volume of your voice. And they can work on cognitive impairments. So a lot of what they will work on is strengthening of the oral cavity. So the mouth, the tongue, the swallowing. They can give recommendations on diet modifications, because at some point, sometimes it's just not safe for us to eat certain things anymore. If it's something that you're kind of always choking on, or you're coughing a lot when you're swallowing something, they can do swallow exams with video to see if things are slipping down and you're not swallowing appropriately. And if they need to, they can also recommend communication devices. I think another thing on here too that I didn't mention is the diaphragm. They can work on breathing and kind of how well you can exhale and really get that voice out to help with getting your message across also. We also have additional services that are part of our rehab family. So there's also integrative therapies, which can provide massage, acupuncture, and mind-body approaches just for pain management techniques. Then there's also social work services that can help get you established, or they can help establishing connections to community resources for psychosocial support. I know a lot of people, there's a lot of resources out there for MS, but sometimes getting the appropriate services for them or finding those services can be challenging. So that's something that social work services can help with. Overall, for all the research studies that they've been doing, and they've been looking at clinical trials on what the best route is for therapies in general. And they have found that in addition to being followed by a neurologist and any medical information that's being provided to you and medical recommendations, whether that is medication or not, but there is moderate evidence of long-term gains in mobility, increasing your mobility and your safety, increasing your strength, decreasing fatigue, and increasing your quality of life with a comprehensive approach to multiple sclerosis. And what they looked at mostly with that is physical therapy, occupational therapy, and speech therapy. There were other things that they also looked at, but they were small studies and it was hard to see if they were really beneficial. But the trials that they looked at included over 10,000 participants, and they're continuing to look at those trials as well. I think a big take-home message for anyone with MS, like Dr. Filippakis already mentioned, is general recommendations is to exercise. So general recommendation that we make is 150 minutes of physical activity a week. And I wanted to point out that we call it physical activity and not just exercise, because there is the wide array of disability. So there could be someone who has mild impairments, or there could be someone who is wheelchair bound or bed bound with MS. And that doesn't mean that they can't necessarily partake in physical activity anymore. It just means that their physical activity looks a little bit different. So some of the general ones that I just wanted to point out is walking. So walking does include with or without an assisted device. People ask me all the time, well, I'm walking with a walker, I'm not walking. That's still walking. And we still want you walking, even if it is with a walker. That just makes you safer. Things like Tai Chi and yoga can be good for flexibility and overall just movement. You can use things such as free weights or dumbbells, kettlebells, resistance bands. You can work on range of motion exercises, breathing exercises. So again, just because you're in a wheelchair or you're bedbound doesn't necessarily mean that you're not working. It just means that your activity looks a little bit different. So that's why I wanted to point out that breathing exercises and range of motion exercises, even that if it just means laying in bed and moving your legs around, doing a couple stretches, sitting in your chair and doing some tricep push-ups, that's still moving your body. Working on your posture is also huge. We all need it. Whether you're walking around or not, we all need to work on our posture, which is also physical activity. So I think a lot of people think that they need to be out running and hiking and doing all those things. And if you can, that's great. But also just moving the body in general for 150 minutes a week is what we really recommend. And if you go through therapy, we can help to set you up with a home exercise program and make sure that what you're doing is safe for you.